we are very excited. Let me tell you, I'm sure Ajit and my other colleagues are as well. So the excitement is still there.
Just want to ask you, is there any difference, and maybe ask Dr. Colombo also, in the late loss between absorb and the stent at 1 year and 2 years, both in terms of angiographic collab and OCT and IVUS? Dr. Colombo or Praveen, any of you?
As we all know, late loss is very dependent upon the strut thickness. We can go back to the ISA Stereo 1 and ISA Stereo 2, which were done with bare metal stents, and both studies definitely showed that the late loss is less if you lower the strut thickness. So the fact that with MES 100 we have less late loss compared to absorb is well expected, because we have a significant decrease in strut thickness. So I believe this is a very fundamental advantage that not only goes into improving deliverability, but lower late loss, lower the risk of thrombosis, makes the stent more contemporary to new generation DS.
Dr. Chando, I'm Dr. Hajra here. Can I ask you a question here? Do you think the late loss, more late loss, is a kind of blessing in disguise in comparison to other stents like absorb? Because that will prevent the wall collapse in the future. And second is, what about the periprocedural MI? I mean, is there any data available about the periprocedural MI? Because this is the burning thing in 2021 after the Excel trial. Over to you, sir.
Yeah, so Dr. Hazra, I think these are very important questions. And the thing is that, in this, although, we cannot answer all the questions from these studies with 155, 160 patients, because what happened was that in this study, we did not take any bifurcation lesions, not take any very complex situations, very calcified lesions. So I think at this point in time, we can say that for these lesions, it is very, very safe and does not any increase post-procedural MI. But certainly we will look at this eventually, and with any stent, some percentage of these events is to happen, because side branches will block off. There will be, smaller vessels or even longer lesions, etc. So that is bound to happen, but definitely it shows that as such, the device does not lead to these kind of events, number one. And number two, as Dr. Colombo already mentioned, that the thin struts are really making the difference, and the ingrowth, the deposition which is happening over these devices is leading to safety of these stents much earlier than the absorb stents.
Dr. Praveen, one question. What is the cause for, because absorb became breastfeed because late thrombosis was very high. That's why, what is the cause here in this case? We didn't see much of rethrombosis or late thrombosis. The strut thickness is an important factor.
Yeah, I think one of those very, very important factors is strut thickness. And also we learned very early from the absorb experience from Dr. Colombo and many, many others, and our own experiences. We implanted more than, I think, 10,000 stents here in India. And we started learning that very early. And then, of course, we used that experience with when Meris was launched, that we have to do very high pressure implantations. And that is why I think this is an excellent idea that Meris is coming with 2 balloons, so that nobody can just miss not expanding these stents to that extent. So I think these 2 things are making the difference: thin strut and super expansion of these, embedding these struts into the vessel wall.
How important is the bed preparation for mirrors, as the strut thickness is only 100 microns? Do you think it's going to play an important role in putting these devices?
Certainly, I think this was important with absorb also, and this is important with this also, and that is why we are getting 2 balloons with this device. One is for bed preparation, that you do an excellent bed preparation. Otherwise, normally with a metallic stent DES, what we do is even if it is a 3.5 millimeter stent, we dilate with a 2.5 or a 2 millimeter balloon, and then go ahead and put the stent. But with this, we have this balloon, so no mistakes will be done. Everybody will dilate these vessels, prepare them well, and there will be instructions also. If it is not giving way, please do not implant the stent. Use a device which does plaque modification, like cutting balloon, or now IVL is available. Even IVL or Ruta, whatever is required, has to be done before we implant these stents. That's it.
Extra balloon, which I think Sanjeev Bhatt might be able to answer, or Dr. Chandra, that the second balloon which is given is the same size of the strut, the size of the stent, like 3 or
Dr.
or
Vivek,
it is quarter size bigger.
Vivek, I am Dr. Segurvel. I just happened to do a case just now with the bundle. So they have some of the sizes, they have quarter size as well as half size. So the case I did today was a 3.5 scaffold. They had a 4 millimeter post-dilatation balloon. So it is really more importantly, this bundle is very useful. Particularly, you don't have to search for the availability of the right sizes. So you are pretty sure what you want. I feel so comfortable. The length and the size were readily available. So that is the biggest advantage of this bundle, and you have the choice going to 0.5 above.
Yeah, so I think that's very nicely explained by Sangatavelu, because it's very important that when we doing post-dilatation, we can, up to 0.5. So I think bundling of the balloon is very important concept.
Yeah, I think that works very well. So with the 3.5, it is a 4 millimeter for a post expansion, and with I think a 3, it is a 3.25. So, and then one has to be just be careful that if it is a 4 millimeter balloon, and if the vessel size was like 2.9ish or something, you don't have to go to really very, very high pressures in post dilatation. Because
the word of thing is they generally size the vessel, the size of scaffold based on the proximal diameter generally, as opposed to generally we do the distal vessel for sizing. And as Sanjeev mentioned, they can go up to 1. It can go up to 1 above, so it is safe. 0.5 is relatively safe to go with this post dilatation.
Absolutely.
And I would like the opinion of Dr. Colombo is that, do we have scope of further decreasing the strut thickness category as well? Because as he said, that the thinner struts, the better the outcomes would be. So opinion from Dr. Colombo, that what do you think is the ideal magic number of strut thickness?
But as we all know, I think if you go around 190, you reach a reasonable compromise between radial strength coverage and impact upon thrombosis and restenosis. So of course, the lower you go, the better it is, but we all know how difficult it is to maintain radial strength if you go below a certain number, especially when you use no metal device. So I think 100 micron is acceptable. Unless we have some breakthrough in technology, I would not lower the strut thickness with this material if you have to pay a price in radial strength.
Absolutely. I totally agree with that. That 100 micron is still acceptable. And because many stents still, which are on the shelf, metallic stents are in the range of about 80-90 microns still, despite having 50-60 microns. So, and they work very well. So the metal stays and it works. So I think this should also be fine.
And we should not forget that a simple way to lower the strut thickness is to embed the stent into the artery wall. So if you do a good post-dilatation, you may embed the stent 10 microns. So just by this act, you have lowered the strut thickness.
About the ISR of embrace in future, what will be the strategy or your provocative thought on should we go for the same embrace, longer, bigger, smaller, or you go for DES?
So you are asking about the instant restenosis, Dr. Hazra?
Yes, sir.
I mean, I think very exciting, at least a thought to me, and I have done it many times with Absorb, with Mary's now, and it really works out very well, especially for any artery which is bigger than 3 millimeter or more. Because for smaller arteries, I don't think, because there will be too much inside, but for bigger arteries, using a Mary's for in-stent stenosis is a great idea, and you can expand it truly, and then of course once this whole thing is absorbed, then what is left is just this previous stent.
If you have just a minute. If you have a metal stent, you can always go back to the skeleton which you have left underneath, and you can always analyze and see the skeleton, whether it's undersize or proper size. So you do not have those kind of chances once you have emitters there. So again, I think imaging is very important, but what I'm saying is possible. But about the sizing, it should be the same or bigger.
Yeah, the sizing has to be the same. I think we have to go according to the size of the vessel, and because the stents can be expanded. Even if the previous stent was under expanded, we can expand it. But the sizing of the the scaffold which we are going to use in this will be the size of the vessel itself.
So I thank you for your attention and await any questions.
Yeah, thank you, Sanjeev. I think this is a very positive direction which this technology is going to take, and I'm sure this will be the pivotal study which is going to give us much more clear directions and ideas about the use of these devices. Thank you.
Sanjeev, why did we take 200 as the number for imaging? Is there some criteria for that, or is it?
No, not really, Dr. Jeet. It's a good question. We said we would like to have clinical sites with with imaging availability and facility. Not all centers may have the access to OCT. And said clinical sites which will have routine access to OCT was one of the criteria. And this whole method of staging the QCA or angiographic or OCT follow-up was to ensure that we don't have the same set of patients getting called for an invasive imaging every year. So, but as I said, this is the study design per se is still in evolution. And the idea was to study substantial population with OCT imaging. And it is, as a leadership group, if we decide that there is a potential for a minor modification in the design, it's absolutely welcome.
Why not also include a CT arm? CT scans are very good for these patients. We have seen it both in the Absorb and with the Meris which we use, because the clarity is so clear that we don't even need to sometimes image these patients or do an angiogram. So is there a thought about that, or no?
Sure. In fact, Dr. Chandra's slide, you would have seen that in a small population within the MIRES one study, we did MSCT. I recall because of the platinum radiopaque markers, sometimes there is an artifact that one may have to deal with in the CT imaging, but I think it clearly can be worked around. So it's a good point. We'll make a note of this.
So what are the timelines, Sanjeev, for this study? Have you thought
Dr. Chandra, yeah, a good question. The idea was to have the first set of evaluations for the MIRES platform, and since we've already gotten off the ground with your cases, Dr. Singatovelu's cases now, we will, once we have a small subgroup of patients being evaluated by the forum gathered here today, in the meanwhile, we will start finalizing the protocol. The idea is to work with select group of leaders like yourself. Professor Colombo is here, and to tighten our final protocol, write down the long version of the protocol, submit to the DCGI, and start applying for the ethics approval and run the study. So I would expect anywhere about 3 to 4 months.
We have been working for the past 5 years with this concept of metal-free approach.
This is also very exciting, and maybe if this metal-free approach works, my colleagues will agree. Dr. Praveer, I can see Nishit. What do you say about this? I think it is exciting.
Colombo, what will be the post PCI optimized IFR? Conventional DES versus BS, is it going to be same 0.95, or you have a different cutoff for post PCI optimized IFR?
Yeah, we don't use IFR. We just try to make it simple and use pressure gradient. Because, IFR is not fully available, but pressure gradient, of course, if you have a good result, you're not going to spend time to do pressure gradient. If you have a bad result and a nasty dissection, you don't have to spend time. You implant a BRS, no question. But if you have an intermediate result where you are not sure, you feel like to leave it, but you don't feel completely secure, then you measure pressure gradient. And if the pressure gradient is low, Grunzig used 20, but we want to be absolutely safe and use 10, which is very demanding, then you can leave it alone. So far, we can utilize, coming soon, we will have a microcatheter which you can put over any wire, so you don't need to do any exchange wire. You can use a microcatheter to measure pressure gradient. And I really encourage Merrill to produce a microcatheter to be utilized to measure pressure gradients, because I believe we need to go back to measure pressure gradients. IBUS is very nice, but is a little bit complicated. Pressure gradients are simple, easy. The only problem is that we do not have simple devices to measure pressure gradient.
So I think, this was fascinating.
As Dr. Antonio Colombo mentions, that circumflex ostia is the area where one should avoid stent. If you have a gelling, you go for FFR. If the FFR is less than 0.8, you try to quote a study where the FFR is less than 0.75, 0.7. So do you think in isolated large circumflex ostia, is there any scope of this kind of device?
It's a question that if you have a lesion in the circumflex and you want to stent it, would you like to use an bioabsorbable scaffold? Is that the question?
Can I share my experience? So
yeah, sure.
I had presented this in one of the meetings. We had about 10 cases of osteal lesions, and we found very high restenosis with absorb in the osteal lesions. So I really have concerns in using BRS for osteal lesions. Maybe we should have more experience, but maybe, I don't know about Colombo's experience, but personally, I would be one subset of lesion where I would avoid BRS is osteal lesions.
So, Dr. Sengatwell, I think very important observation. And I also did many osteal lesions, but in most of my cases, I actually did imaging and also did a cutting balloon or a rota or something like that, definitely, to get a good expansion of the ostium, because ostiums don't expand so well.
Absolutely.
I think that is the only thing which I would recommend.
Did you restudy them, these osteal lesions?
Yeah, I mean, we restudied them also, and many of them actually did reasonably okay. So, I mean, it's although there was not a randomized trial or any long-term study which we did, but it is absolutely doable.
I have a question for you. You see, the cases were very, very nice. The only thing is that what we have realized that if you just go with the OCT, often you land up in putting in longer stent than what you think. What's your take on that? Often
I completely agree with you, and that's what Dr. Colombo showed, that we want to restrict your number of stents in the vessel.
Yeah.
But if I have to stent, because there is two problems which we are now talking about. One is the problem of when you put the metallic DS, at least, we know that if you are left with a 50% lesion at the distal or the proximal end of the stent of plaque burden, then you land up with complications. And that is at least very clear with the metallic DS. So we tend to, obviously, when we image, put a longer stent and do it to cover from good to good. That's one issue. But the downturn of that good to good is to put a long metallic stent and keep it there forever. But if your issue is that you want this long stent to be say a BRS or a BBS, then it's great, because at 2 years, if the stent disappears, then your two issues go away. One is the stent goes away, and your dual antiplatelet therapy, which you are stuck with in these patients, unfortunately, it can also be going away. So I think that if you're left with the Hobson's choice of putting a long stent, I would rather have a BRS in with optimal deployment and a shorter dual antiplatelet, say, for 2 years. I'm not sure what Dr. Colombo's feel is.
Yeah, this is a very, very debatable concept. I follow very well your reasoning. Nevertheless, I like to the concept of BRS, but still don't forget that BRS is also a foreign body for a certain amount of time. And stenting is not the treatment for atherosclerosis. Stenting is a treatment for critical stenosis. So we should not go into the idea that putting a stent, even a bioresorbable, over an atherosclerotic plaque, we cure the plaque. We cure the dissection, we cure the lesion if the lesion is critical. But we should not, I'm not fascinated by the idea that you should cover all the disease, because some disease cannot be treated by intervention cardiologists. Some disease has to be treated medically. So I think it's a fine balance between extending the stent up to a point, but not overextending. Having a bioresorbable is an advantage, but should not take too much advantage of this. Because if you place 60 millimeter of bioresorbable, is still a lot of foreign body, and you are at the risk of thrombosis because it's a foreign material for a while. So I think we need to fine line between where to stop and where to continue. I don't have a clear answer, but please do not take the idea that to go from healthy to healthy. I don't think, yes, there are some patients that have healthy to healthy, but some patients have disease to disease.
Thank you, Dr. Colombo. I want to just make a small comment on that. So if you have a focal lesion, and if you do an imaging, and if you land the stent from a healthy to healthy segment, then this patient is going to do very well long term. If you have a diffuse disease, whereas diffuse disease, then you don't have a healthy point at all, then I don't think there is any point in imaging. And as you said rightly, you have to just focally stent the stenotic segment and get out.
Exactly. Super, you took the point. If you have a focal lesion, that makes sense to go from healthy to healthy. But if you have a poor diabetic patient with the only healthy, maybe he's artery the tongue, I don't know where it is, a healthy vessel. So there is no way you can land in a healthy segment. So then you have to learn to make a little bit of a compromise.
Yeah, I think this is a very important point, and I think I don't think there's a confusion in short lesions. There's no confusion. Everybody will put a short stent and go home. But even in the short lesions, we've seen this work with ACS patients. You need not put a stent in with many of these patients. You just need to just do a suction maybe, and sometimes go home. And sometimes the lumens are good. They remodel very, very well, and you don't even need a stent for short lesions. In many of these acute STEMI patients, we are now seeing plaque erosions not requiring a stent at all, and we have some work now being published. The second question is in the long lesions. I think that we are still a problem, and I think the approach that Dr. Colombo taught us is the most important approach. I think that we spot stent and leave it rest with functional testing, and maybe not image that much and get confused in where to end and where to stop. And I think these are the very valid comments, and I think it will be great work we need to do for the future on these lesions.
Sangut, nice cases. How short would be the shortest DAPT in BRS? Because most of the trial, TICOs, host reduced, or twilight has excluded this kind of technology. So we do not have any first-hand information about the DAPT.
I think the current recommendation is 3 years, but until we get more data and evidence, we need to wait. But at the present, we have to give at least for 3 years, and some of my patients are given for 4 years.
Okay, I think by the time it dissolves and goes away, I think that's the time you need to continue DAPT minimally. With this stent, we have limited but good knowledge that it goes away between 2 and 3 years. So I think 3 years may be a good reason to continue doing DAPT. Also, we have to understand that unlike the absorb, which we had problems of the scaffold falling into the lumen, which during the dissolution, we have not seen many of these issues with this stent. So I think only time will tell us when we have large registries whether such things ever happen. But if that doesn't happen, I think we will be very comfortable, maybe even for a little shorter.
Ajit, would you think that surveillance CT scan will show the skeleton?
I think the CT is a very beautiful tool for the Meris stent, and I think that it should be the way we go ahead. I don't think we need the OCTs on follow-up only for a limited number of times on limited number of patients, because that will tell us what is happening in the pathophysiology, especially how it dissolves, when it goes away, and does it dissolve sometimes by breaking inverts like what we saw with the absorb. But on routine, I think a CT is good enough. I've never had a problem with the markers at the tip, platinum markers, creating any problem in my decision of whether to intervene or not.
Thank you.
Yeah, so let me just clarify. We don't see the skeleton on the CT. We only see the markers and the lumen. So that's how it comes up on CT, and many times even the radiographer will call you saying that we see something abnormal, because if they don't know that there are these markers, sometimes there's a confusion. Otherwise the vessel looks absolutely normal.